Hello, my name is Dr. Kiran S Shankar, and I'll be taking the topic pit and fissure sealants, as it is an important topic when it comes to syllabus and also when it comes to the preventive services in dentistry. I'm from the Department of Public Health Dentistry from PMS College of Dental Science and Research. So, caries has decreased in developing countries in the past several decades. Caries occur most frequently in the occlusal surface. They account for only 12.5% of all tooth surfaces. Caries potential is directly related to shape of pits and fissures. Fluorides are effective in preventing smooth surface caries, and hence currently caries has become a disease of pit and fissures. Sealants physically obstruct the pits and fissures and are safe and are effective. This is how you can see the toothbrush is too large to remove the bacteria from the pit and fissures. So the importance of pit and fissure comes to play. Whereas in history, in Miller in 1905 tried to apply silver nitride to prevent caries. And in 1923, prophylactic odontomy in which non-caries surface was restored with silver alloy. Buonocore in 1955, acid etching as a method of adhering resins to enamel surface. Pavanachal in 1965 developed the best GMA resin. So types of pit and fissure sealants include it is classified according to the generations. First generation activated by UV light, second generation by chemical curing based on catalytic accelerator systems, example concise 3M. Third generation activated by the visible light, example Fissure and Dalton. Fluoride containing sealants with as the most effective and its double protection. And again, is based on fillers. It's a freer fillers, flow is better, semi-filled, more resistant to wear. Based on color, it is clear, aesthetic but difficult to detect all at recall exam. Tinted can be easily identified, opaque can be easily identified. The morphology, shallow, wide V-shaped fissure, deep, narrow-shaped fissure, which is constricted and resolves a bottleneck. Procedures include polishing the tooth surface, isolate and dry the tooth surface, etch the tooth surface, rinse the tooth, isolate and dry the tooth, apply bonding agent, material application, evaluate the sealant, check occlusion, retention and periodic examination. Coming to polish the tooth surface, important to remove plaque and debris from enamel and pit and fissures. Debris will interfere with proper etching and sealant penetration, done by prophylaxis cup and pumice. Isolate and dry the tooth surface. Rubber dam is the best method. It is important to keep tooth free of salivary contaminants irrespective of method. Etch the tooth surface. Etch with 37% of orthophosphoric acid for 15 to 30 seconds. Etch and apply to all pit and fissures to and at least a few millimeter beyond final margin of sealant. Etchant shouldn't come into contact with soft tissues. If it happens, you have to rinse thoroughly. Rinse the tooth. Rinsed for 15 seconds. It is important to ensure removal of all etchant material irrespective of the time. Isolate and dry the tooth. Dried with compressed air till tooth has a chalky and frosted appearance. If it doesn't, you have to re-etch again. And moisture contamination at this stage is the most common cause of sealant failure. Isolation is not considered seriously in many of the Indian dental scenarios. So this is something that we know that we have to take more importance, because how many of us use really rubber dams? So it is a complicated, it feels like a complicated procedure and expensive procedure when you're using a rubber dam, and time consuming. That is what most of the dentists say when it comes to use of rubber dams. But still, it is the best way. If we are contaminating the area, then we are doing more harm to the patient than prevention of caries. So you either do it perfectly or don't even bother to do it. That's the thing. You have to do it properly. Apply bonding agent. Intermediate bonding agent is applied and cured. Material application. This is the highlight part. Applied according to manufacturer directions. Each material comes with different instructions. Care should be taken to avoid incorporation of bubbles. After sealant has set, wipe seal surface with wet cotton pellet. This allows for removal of air-inhibited layer of non-polymerized resin. Not removing this will cause an objectionable taste in the patient. mouth, evaluate the sealant, evaluate it visually and tactically. Use the explorer and attempt to dislodge it if deficiencies are there. For more sealant material is applied. If in case we have to thoroughly evaluate the sealant to see that if the sealant is placed everywhere, so visually and tactilely we have to see. Use the explorer again and again to and attempt to dislodge it. If there are air bubbles, it will come off very easily. So then again, check for occlusion, check for occlusal points. If they check if there are any high points, we have to see that, you have to ask the patient to chew and see, adjust if needed. Studies show that filled sealants require more adjustment than unfilled sealants. Then again, retention and periodic maintenance essential to re-evaluate sealants at recall visits. New sealant to be applied over old if sealant loss has occurred. This periodic maintenance part is something that we find it difficult to maintain, because periodic maintenance in between we have to see if it is done or properly placed. Then the periodic maintenance is the part where patients lack. Basically, they don't come back and see to reevaluate the sealants is done properly. We have to motivate properly and select patients also accordingly, so that they come for periodic maintenance after the sealant has been applied. So the points to remember include: require good moisture control when being placed, clean surfaces are needed, appropriate etching and drying time is needed, appropriate occlusion checking occlusion has to be done for interference. Regular monitoring and maintenance after placement has to be done. These are some points to remember that we always tend to forget, and it is always important to remember that you have to isolate properly. If there is moisture control is not maintained properly, then it becomes very difficult. And the clean surfaces and appropriate etching and drying time and appropriate coverage of the surface, checking occlusion for the interference. And as I said, if it is not done properly, it is better not to be done. So we have to understand on what type of patients we have to do it first. Patients with continuing caries risk, who have fissure caries just into dentine. Patients with continuing caries who have fissure caries just into dentine prefer to amalgam placement, as it requires less loss of tooth structure and provides full occlusal protection against caries. Placed over glass ionomer cement within cut fissures if space allows, and then monitored and maintained. Not much use in primary teeth. These are the indications. So far, some of the factors affecting sealant life. What are the factors that affect the sealant life? Case selection. Okay, case selection is an important factor. You have to understand what type of cases you have to go through preventive services, or topical fluoride application, or even if it is pit and fissure sealant. You have to select an ideal case. The case has to be indicated, highly indicated. We saw the indications already. And also we have to see if the patients are cooperative, and they will come for follow-up and periodic maintenance. We have already mentioned about the importance of periodic maintenance. All this periodic maintenance is needed. So appropriately a case has to be selected. So only if the patient is sufficiently motivated for this kind of treatment, we have to give. Otherwise, it becomes a double-edged sword. Basically, if you will be doing more harm to the patient than preventive services. But the motivation is an important part when it comes to public health dentistry as well. We have to give sufficient health awareness, the education and motivation when it comes to preventive dentistry. Then again, tooth selection. We have to select an appropriate tooth where the fissures are deep enough. So that the brush bristles, it is not occlusal caries, fissure caries, which cannot be removed by bacteria, which cannot be accessed by normal tooth brushing. So these are caries, you should be able to identify which type of tooth, and also there is a tooth which accessibility is less when it comes to brushing the teeth. All these conditions, mainly occlusal surface is the main part when it comes to fissure sealants. And tooth position in mouth, as I told, you have to know if it is accessible enough, how it is affecting the patient. Again, age of the child, eruption status of the teeth. If you are using the appropriate technique, the instructions by the manufacturer, you have to follow this because each of the sealant material have a different kind of setting time and curing time. So you have to see the instructions given by the manufacturer so that to do it accordingly. Clinical skill of operator, then bonding agent, the maintenance, all this you have to see, and which are the factors affecting the sealant life. Then see coming to sealant retention, that is the success measured by the longevity of sealant coverage. Studies by Siegel in 1998 shows 5 to 10% failure rate per year. Report observed that second generation sealants provide more protection than one. Chemical and visible light are similar in retention. Bonding agent is also important. Better retention for anterior teeth and mandibular than maxillary. So you have to see the sealant retention also. If it is not, it is coming out easily, then it is of no use. These are the indications and contraindications for the use of Pitt and Fisher sealants. You have to understand when you can seal and when you should not use seal. When the surface is carious, clinical consideration is the occlusal anatomy. And do seal if pit and fissures are separated by a transverse ridge. A sound pit or fissure may be sealed. Do not seal if the carious pit and fissures. Questionable, that is clinical conditions, status of proximal surfaces, general caries activity, and do seal if there is many occlusal lesions or and few proximal lesions. Sound, occlusal morphology, deep, narrow pit and fissure do seal, broad, well coiled pit and fissure do not seal. Tooth age, if it is recently erupted, do seal, and do not seal if teeth caries free for 4 or years or longer. Status of proximal surface, if it is sound, do seal, and do not seal if it is carious. General carious activity, many occlusal lesions and few proximal lesions you can seal, and many proximal lesions do not seal. So you have to understand if there is any proximal lesions, it is better not to seal. When to seal and when to not to seal is an important aspect when it comes to preventive pit and fissure sealant therapy. So you have to understand which is broad, if the fissure is broad or if it is narrow. You have to see the occlusal morphology, all that, and on the basis of caries classification, you have to see and you have to decide if it is to be sealed or not. So coming to incipient fissure caries and sealants. Sealants decreases bacteria counts and eliminates nutritional source. Neutralizes incipient caries lesions. Invasive technique where fissures are whitened with burr before placing sealant. This helps in diagnosing caries extent, ensures high retention, reduces risk of micro leakage. In case of deep and narrow discolored fissure, invasive pit and fissure sealant should be used. Primary preventive approach versus early treatment approach. The consensus panel in 1983 concluded that evidence supports use of sealants to arrest progress of caries and lesions. Studies conclude that when sealants are applied over a stained fissure with no softness of base and no cavitations, caries progression is arrested. Recent thinking is that even halts the dentinal caries. Coming to just an overview of preventive resin restoration, it was reported by Sebastian Stallard. Involves removing only carious areas and then sealing it. Conserving the tooth structure is one of the important fact, and effective in class 1 restorations. Indications for caries which has just reached dentine. In early decay, possible glass adenoma when it is unfilled should be used. Difficulty in differentiating the depth of caries lesions. The fluoride containing sealants are the latest revelation and is was of two types. And soluble salt is added to polymerize resin. An organic fluoride chemical bound to resin benefit is from fluoride absorbs to enamel, and this is questionable. No clear evidence of benefit of fluoride sealants has been seen. Sealants. Preventive technique with a minimal tooth loss. Amalgam is restorative technique with considerable tooth loss. Sealants with sealant loss, replication and continued protection and intact tooth. Replacement of defective restoration causes more tooth loss. Time taken less, whereas in amalgam it is more. Sealants cost effective on long duration, cost effective on short duration. Amalgam. ADA accepted sealants. You can see the text and see the programs. The main of the thing is main important fact is cost effectiveness. Cost effectiveness. It defined as the least expensive way from among the competitive alternatives for meeting a defined objective. That is caries reduction. Okay. So in public health, choosing a strategy to prevent caries depends on a variety of factors. Careful choices and sound program evaluation will help in developing an effective prevention at community.